Thank you, Sharon. Thank you, everybody, to be here at this time. It's my pleasure to present some very recent data about two studies. And first of all, I want to thank the sponsor, Mindray, especially Dr. Fiona New for her support. And I will start now. These are my conflict of interest. It's only consultant. So I propose you in the next 15-20 minutes to try to answer the 5 questions. Why should we optimize preoxygenation both in anesthesia care and in critical care patients? I try to convince you the rationale to combine 2 techniques of preoxygenation instead a single one. And I will give you for the first time, we will present the OptiMask study, which is a study, which is an international study performed in OR. And we'll present you OptiNIV study results, which was performed in hypoxemic critical care patients. And we will finalize the presentation by some key messages. This slide show you a healthy lung, a patient in anesthesia, healthy lung or in ICU, and the rationale for preoxygenate is to have the maximum oxygen stores in the lung to make a denitrogenation. So when you use just a balloon to deliver oxygen before preoxygenation, for example, here you have 100 millimeters of mercury, and after 3 to 4 minutes of oxygen balloon, you can reach around 400 millimeters of mercury for a healthy lung. This allowed to you, in case of difficult intubation, in case of complication, to have time to change the plan B or something. And then you can wait from 5 to 6, 7, 8 minutes in healthy lung. So, however, this is not true in injury lung patients. For example, for this, you know that you have reduction of lung volumes. And then, for example, in this patient, the PO2 is around 60 millimeters of mercury under ambient air. And after preoxygenation with the classical oxygen balloon, you cannot probably reach 100 millimercury. So the oxygen reserve in this case, it's very low. And then if you have some difficulties for intubate the trachea of this patient, you can have anoxia in this patient and death can occur. Moreover, with this situation, as you know, when you make an induction of anesthesia, this is a CT scan of before anesthesia, and just after, you can observe here the atelectasis will occur rapidly after just 1 or 2 minutes in the dependent part of the lung. And this is more exaggerated in obese patients. So one proposition made here by the group of Edenstierna first is to use a positive pressure, like a continuous positive airway pressure, to prevent the apparition of this atelectasis by using, for example, here, a CPAP of 6 centimeters of water level. And then you can avoid the apparition of atelectasis and then improve oxygen storage. So the rationale to use different techniques is the following. I summarize on this star the main preoxygenation technique, old and new. First one is the standard fast bath mask, or the equivalent. The second one is now we have data using high-flow nasal oxygen therapy, like THRIV, and which allowed apneic oxygenation. The third one is non-invasive ventilation using pressure support ventilation alone or CPAP alone, that means a PEEP. That means positive pressure to prevent the derecruitment. And then you have the 3 major old preoxygenation techniques. And then if you add the 2 plus 1, you have the OptiMask, is the association of the standard mask and the high-flow oxygen therapy. And if you add the high flow with NIV, you obtain the OptiNIV. That is the rationale of why we wanted to evaluate the combination to add the 2 techniques, maybe improve the oxygenation techniques. So to summarize, the rationale is the following table. As you see in this table, I put in the left, in the column, the 5 techniques, and you see here in the table the far major way to work. To deliver higher VO2, it's not possible with the standard fast mask. It works when the patient breathes by mouth open. It's not allowed apneic oxygenation and no positive ventilation. If you see what happened with high flow nasal oxygen cannula, it can deliver higher VO2. It cannot work with mouth open, and we can have apneic oxygenation and not positive pressure or a very little, very low level. What about an IV? Yes, you have higher VO2, close to 1. It works when the mouth is open when you use a facial mask. It cannot allow the apneic oxygenation, and it delivers positive pressure. So if you associate opti mask, that means fast mask and high flow, you have the higher VO2. You have, it works with the fast mask because it can deliver when the mouth is open. And you have oxygen apneic deliver, but you cannot have positive pressure. And finally, what we could be the gold standard is probably the Optiniv techniques, with can deliver higher VO2, can work with open mouth, and you have oxygen apneic with high flow, and you have positive pressure. This table can summarize the main works of different strategy and why we can associate two techniques and could be synergic. However, to our knowledge, no study evaluated the OptiMask strategy in anesthesia care. That's why we performed this study, which is an international study leading by the group of Boston of Danny Telmore and our group in Montpellier with Audrey De Jong and two centers in China, in Zhengzhou and in Shanghai. And this study was supported by Mindray, and I want to thank especially Dr. Fiona New, which allowed us to perform this study with the new ventilators. The main objective of this before-after international study was to evaluate if OptiMask strategy, a new one, compared to the standard balloon one, could improve the oxygenation. We used for this study a surrogate of the oxygen quality, which is the lowest end-tidal oxygen after intubation. This is a surrogate of how the oxygen could be used in the lung of the patient. As you see here, the main hypothesis is the new technique OptiMask, the association of both, could be better in comparison to this oxygen standard alone. This is to explain you the strategy of during preoxygenation, the patient can breathe with the mouth open, and then you have all the two technique oxygen high flow delivering around started with 30-40 liters per minute, and when the patient is sleeping, we can increase at the maximum delivery by the machine. That means 15 liters per minute. And then you have the mask that you can deliver also oxygen by the mouth. This is after when you finish the anesthesia induction, you remove the face mask and you have the technique of oxygen apneic oxygenation, the TRIV, and then you can perform, for example, in this patient, a video laryngoscopy. I don't remember exactly the number, but some centers use systematically the video laryngoscopy, like in Montpellier, and some use only Macintosh laryngoscope standard. This is a machine that was used in the 4 centers, each a Mindray anesthesia workstation with an E8 and E9, which allowed to deliver both high-flow oxygen therapy and oxygen standard. The results are the following. 450 patients have been included, all consecutive, and the primary endpoint, which was the lowest end-tidal O2 within the 2 minutes after intubation. As you can see here, we have significantly lower in the standard group in comparison to the new one. As you see here, the median value and the mean value. The same is true in patients without obesity, and the same is also true, and more difference is in the obese patient. So this technique works in every patient. This is a concept proof of the study, and it works, and it was safe. And this is the future study that we want to perform now, because we tested the two strategy. We wanted in the next step to test the Optiniv, the Optimax. This is a group of combination in comparison to the 3 standard strategy in a randomized trial. This, we hope, it's the next step with all the group, we hope. So what about the ICU? This is a study leading by Audrey De Jong. Professor Audrey De Jong performed a big study with mixing all our database, and we reported 5 independent factors associated to the cardiac arrest during intubation in ICU patient. And as you can see, we have 2 non-modifiable factors, which is the elderly and the overweight and obesity. However, you have 3 that we can improve. It's mainly hypoxemia. As you can see, the odds ratio is around 4. You have 4 risk more to have a cardiac arrest when you intubate an hypoxemic patient in ICU. So optimizing preoxygenation in this patient is really crucial and challenging. And then we developed first more than, as you see here, close to 20 years. When I was young, this strategy that we developed when I worked in Créteil, and then after we developed it in Montpellier, and we compared NIV in comparison to standard oxygen. And then here you have in y-axis the oxygen saturation in the oximetric pool, and then here you have the baseline. You can see here the hypoxemic patient, and here is end of 3-minute preoxygenation, and this is the lowest value obtained during the endotracheal intubation procedure, and this is 5 and 30 minutes after during spontaneous breathing. That means balloon. And when you do the same with NIV, you can see you have an increase of the lowest value here. This is NIV, and this is some data coming from different groups in France. This is from the group of Jean-Damien Ricard. It's a before-after study using high flow, and showed this study in mild to moderate hypoxemia ICU patient. You can use high flow oxygen therapy. However, when we performed the first randomized French study, we found no significant difference between high flow oxygen therapy and here standard oxygen. So why this is the case? Probably in this case, when you put high flow oxygen and you remove the balloon, probably you lost some pressure and lung volumes. So that's why we combine both. Optiniv is OptiFlow, high flow oxygen, plus non-invasive ventilation, to try to win the effect of the positive pressure that could allow alveolar recruitment, and use apneic oxygenation during intubation using high flow oxygen therapy during the laryngoscopy, which could deliver oxygen continuously. Then combining both, we performed this trial. As you can see, it was a double-blind randomized trial, also performed with Audrey De Jong. And we can see the same results. The y-axis is the minimal SpO2 value that you can observe it. And this is the NIV alone. We confirm the previous results. And when you use high flow oxygen therapy plus NIV, that means Optiniv, you can see here you have a significantly increase of the lowest value. And then now it's coming, it became our standard of care for the more hypoxemic patient. And if we summarize all the results available in the literature now, you can see first the value with the balloon oxygen is obtained a value around 85 to 88. If you use here only high flow oxygen therapy, it's around 90. If you use NIV, it's between 92 to 94. And if you use Optiniv, that means the association of high flow and non-invasive ventilation, you can reach 98, 100%. That is probably could be the standard for the future for the more severe patient. So the conclusion, Optiniv shows that it could be possible to improve oxygenation in OR in the patient with obesity and without obesity by improving the end-tidal oxygen levels. And Optiniv could allow the oxygenation in the more severe ICU patients. And then now we think that probably in conclusion that time to change the classical paradigm which opposite the preoxygenation technique and try to have a new paradigm which could allow to combine additionally two preoxygenation synergic technique, which could allow better preoxygenation in comparison in a single technique. Thank you very much for your attention.